Hi, it's Diane Ames and Katie Dykes, and we're going to be reviewing some common sleep problems with the older adult population. And this is a common problem when you're working in clinic that oftentimes older adults will come in and will want to discuss with you. So, hope you enjoy it.
Thank you, Diane. We're going to talk today about the epidemiology of sleep problems in older people. And I will say this is a very common thing. People come in the clinic and say that they can't sleep like they used to. Most people are of the firm belief that they need 8 hours of sleep a night. It's been drilled into them, and that they shouldn't be waking up during the night, that they should sleep straight through solid, and why do they wake up all the time? So it's a very common thing. And people that are in institutional settings that are unfamiliar to them, like a nursing home or in the hospital, often have sleep problems because of the unfamiliar environment and noises, and the bed isn't comfortable. All different reasons for that, but it's a whole different scenario in institutionalized people than it is for people at home in their own beds. So that being said, let's look for some of the risk factors that account for insomnia in the most of the people that we're going to study. Chronic illness is one of them. For example, COPD, if you're coughing a lot or short of breath, you're going to wake up a little more often or not sleep as well. If you have CHF and you need 5 pillows to sleep on to breathe. If you're taking a diuretic for congestive heart failure, you're going to be going up to go to the bathroom even if you took it in the morning. If you have BPH, you're going to be running to the bathroom during the night. So chronic illnesses are going to interfere with your sleep. Even arthritis in terms of pain sometimes can make people uncomfortable enough to wake up. Mood disturbances, obviously people with depression or bipolar disorder, have a manic phase or whatever, you're going to have sleep problems. People with less physical activity, if you just sit around all day in a recliner and doze off for 20 minutes out of every hour, you think you're not napping or you're not sleeping that much, but in reality you are getting plenty of sleep during the day, and you're obviously not going to be getting much sleep during the night, or at least the quality that you think you should be. And then physical disabilities also can account for insomnia. If you're so weak that you cannot reposition yourself and you're developing just some discomfort from laying on one position for too long, you need somebody to come and turn you. Obviously that's going to contribute to insomnia as well. So it's often comorbid with other conditions. Fairly common. Decreased sleep efficiency. This is well known among older adults. Time of sleep divided by time in bed. A lot of people go to bed at 10 o'clock because that's the time you're supposed to go to bed, or that's the time the news starts. No matter how tired they feel, if they're not really even that tired, that's their bedtime and they go to bed. It's their routine. So if you're not ready to go to sleep and you go to bed and just sit there and watch TV or read a book, or just lay there in the dark with your eyes open and glance at the clock every 5 minutes, obviously this isn't good use of your bed. You're not sleeping when that's what your bed is for, is to sleep. So actually, if you're not tired, you can encourage people to stay up later and do something, because they're not going to be falling asleep anyway. And it can vary, the amount of sleep you need can vary from day to day. So you have a decreased total sleep time when you get older. Older adults necessarily, they actually have a 4 to 5 hour span is a good span of solid sleep for older adults. And you can take a nap during the day to compensate for the other hours. But when people in the nursing home, I always am amazed at the staff that tell me so-and-so can't sleep through the night, but they eat dinner at 5 o'clock. Then they get the lift out when they're done eating and put them in bed at 6 o'clock and the lights are out. And then they wonder why they're up at 2 or 3 in the morning. And I'm like, well, they got a good night's sleep. They're up early because you put them to bed really early. So it is normal for adults to need a total decreased amount of sleep time. And most older people don't know this. So there's an educational component, letting them know they might not need as much sleep as they used to. They might have a stable sleep latency period. Sleep latency is the time that it takes to fall asleep. And some people take a little longer, but if you're really tired and when you go to bed, you should require the least amount of sleep latency. So that's the whole goal of when you go to bed, be tired when you go to bed. Don't, if you feel wide awake, don't go lay down and try to make yourself fall asleep. If you go to bed earlier, you're going to get up earlier. So obviously, like I just use the example for the nursing home, early to bed, early to rise. That's the old saying and the old adage, and it's true. If you have more arousals during the night, that's very common with aging. Sometimes it's due to a diuretic that you take. Sometimes it's due to BPH. Sometimes it's because you're in the nursing home and they come in every 2 hours to turn your roommate and the lights are flipped on and it's noisy. And then you have to go back to sleep every time that happens. So all different kinds of things can enter into the arousals during the night. More daytime napping. If you don't have to be anywhere all day and you're sitting in a recliner and dozing off during a TV show or in, whatever, you're getting sleep during the day, and this takes away from the need for total sleep time at night. And then if you have decreases in the deeper stages of sleep, this occurs with aging. So when you're always in a lighter stage of sleep, you are more easily aroused, obviously, and that is another change that's very common with aging, and older adults don't necessarily realize that they are in lighter stages of sleep, and that's a normal change with aging. So the things that you can ask people in the office, usually they'll bring it up themselves, quite frankly, if they're having a sleep problem. But if you think they might be because they're saying that they feel fatigued, or they're not mentioning a sleep problem, but they don't have the oomph that they used to or whatever, it's a good way to screen out how their sleep is going. So ask them if they're satisfied with their sleep. And they might say, oh no, I take care of my wife. She has Alzheimer's. She's up all night, I can't even fall. I'm afraid to fall asleep. I'm afraid she's going to go outside or fall or be up in the house and get herself hurt, or and I won't know it. So they always have to sleep with one ear open on their spouse, or they'll come up with some reason if they really recognize how their life has been during the night. Or does sleep or fatigue interfere with their daytime activities? You can ask them that. And, they'll be very honest with you. They'll say, yeah, I can't even drive a car if I stop at a stop sign. I'm dozing off, things like that. Does their bed partner, if they have one or others, complain of unusual behavior during sleep? And this would be snoring, an indication of obviously sleep apnea, a risk factor for that. Interrupted breathing, another thing that has to do with sleep apnea. Or leg movements. People that have restless leg syndrome, their bed partner will tell them, if they have certain things. If they don't have a bed partner, it's really harder to know if they have sleep apnea or restless legs, because there's no one to report it to them. So how do you evaluate sleep in the office? You can have the person bring in a sleep log, tell them to write down when they went to bed, how long it took them. It's hard to tell how long it took to fall asleep, but you can kind of remember when's the last time you remember looking at the clock or whatever. And
I have this device called a Fitbit, and it actually is like a souped up pedometer, but they also have a wristband that you can take this, the actual Fitbit portion of it, slip it into this band that you wear around your wrist. It's not heavy or anything like that, and it actually will give you a chart, or it'll tell you about what time you went to sleep, how long you were in bed before you went to sleep, and then how many night awakenings that you've had. And then, when you get up, you just, hit the button so it stops it.
Wow.
So it's kind of interesting. I mean, I'm a person who's up a lot at night, and the last time I had put it on, I had 29 night awakenings. And then I thought, oh, I better not wear this for a while. I'm tired just looking at my stats on there. But actually, they do have some mechanisms that you can check, actually, if you suspect people have an issue. I don't know if the sleep labs are giving out anything that's portable. Probably not, because they want to make the money to have the person come into the sleep lab. But there are devices out on the market that you can purchase. And this was called a Fit, F-I-T-B-I-T. And it was about $100. You can get it at Best Buy. And I got it because I wanted it for steps. And it climbs. It'll tell you how many stairs you climb, that kind of a thing. So it's a motivator.
Yeah, it was part of a whole package.
Right, but it also gets at the sleep. That's the first
Oh.
one that I saw that you can just buy without any kind of prescription or whatever.
That's good to
It's
know,
kind of an
Diane. I've
interesting
never
thing.
heard of
Yeah,
that.
Fitbit.
Yeah, very nice. So Best Buy, right?
Yeah, I went to Best Buy.
I know our office does give out an overnight portable that you can take home and do a sleep study at home. And obviously, usually what they do is if they screen you with that and it shows that you have some problems, they'll bring you into the lab then for the more extensive
Mm-hmm.
sleep study. But some people don't have any problems and then they don't recommend it. So
Okay.
that is an option at some clinics to get the take-home overnight kit or whatever.
That's
So,
great. I've never worked in a clinic that's had a take-home
mhm.
device, so that's awesome.
So a patient sleep log, again, can be helpful to evaluate the person's sleep pattern or get information from their bed partner, like I said, about, if they stop breathing or if they have restless legs or things like that. Some people actually fall out of bed because their legs are so restless. I've had people tell me that they wake up on the floor a couple times out of the night. Or their spouse will say, my legs are all scratched up from their toenails because they kicked me all night long and so forth. Focused physical exams should be guided by evidence from the history. So you look at things like if they're having problems with breathing, are you going to send them to ENT to check for things? You make a referral like that. Or send them to the sleep lab or whatever. Conducting mental status testing because dementia is often a factor. In fact, early stage dementia can interfere with sleep. So doing some just early cognitive screening can be helpful. And then look at the findings of the history and physical exam, and that should guide the lab testing if you send them for a sleep study. Polysomnography or a sleep study is indicated if a primary sleep disorder is suspected. And that would be like something like sleep apnea or narcolepsy, people that are falling asleep during the day. Periodic limb movement disorder, that's usually reported by a spouse or somebody that knows they're waking up and their legs are going all over and they're half out of bed. Violent or other unusual behaviors during sleep. Some people act out their dreams or talk to other people and they're actually asleep. Or sleepwalking, another problem. People that get violent during sleep, they start hitting at things because they're not awake but they're dreaming or have thoughts about violence and are acting them out while they're asleep. Or if a person doesn't respond to treatment, if you give them, relaxation exercises, or they follow good sleep hygiene, or they take some over-the-counter product to help them sleep and nothing is working. These would be times that you would send them for a sleep study. And I mentioned the in-home portable monitoring and the wrist activity monitor is what Diane mentioned. And then insomnia is usually comorbid with a psychiatric, medical, or neurologic illness. There's usually a reason behind it. There's most normal people, if they are active during the day and aren't sleeping a lot during the day, can sleep at night for a given length of time. If people have difficulty falling asleep or staying asleep, waking up too early, for example, or sleep that is non-restorative, they're waking up so often that it's just a very poor quality and is associated with daytime impairment, you're tired during the day, those would be the sleep latency or sustaining sleep difficulties. Some of the medical problems that can contribute to sleep difficulties are like pain from arthritis, I had mentioned that earlier. Paresthesias would be like your restless legs. They feel like their legs have something crawling on them, or they have burning in their legs, or that they have to move their legs to get rid of the discomfort. People with frequent cough, that can be from congestive heart failure, silent aspiration, just a acute illness, COPD, different things. Dyspnea from cardiac or pulmonary illness. If you have congestive heart failure or you have a COPD or whatever, some people just need several pillows or the head of the bed elevated or medication of some sort to help their breathing, facilitate their breathing a little bit so that they can sleep better at night. Esophageal reflux. A lot of people, especially if they lay down too soon after a meal to sleep, will have problems with GERD. And then nighttime urination that's probably the one I hear the most commonly. people are taking diuretics, or people have BPH, or just the normal decreased bladder volume that comes with normal aging. People just need to get up more during the night. And sleep can be impaired by diuretics or stimulating agents. And stimulating agents would be things with caffeine in them, like they have hot chocolate before bed. Even alcohol can be stimulating. If you drink too much before bed, you might fall asleep initially, but you will wake up within a very short amount of time. People that drink coffee or tea at bedtime, I recommend them switching to herbal tea. A lot of the soft drinks, maybe they don't realize have caffeine in them. So I'm looking at stimulating agents, even doing exercise or something very stimulating mentally before bed can keep you awake after you lay down. And then some antidepressants, anti-Parkinson agents, and antihypertensives, such as propranolol, can induce nightmares and impair sleep. So sometimes if that happens with those, you might want to change the time of day that you take the meds. What contributes to sleep apnea? What are some of the risk factors? If you look at a patient in your office and think, gee, I wonder, they don't have a spouse or a bedmate to report symptoms, but they do look like they have some risk factors for sleep apnea. What would those look like, or what are those? Large body mass, being overweight. Normal body mass is up to 22 to 27 is normal, so over body mass index over 27. Actually, if they report falling asleep at inappropriate times, like they're actually sitting there at work and they're asleep on their desk or whatever, or if they're falling asleep at the steering wheel when they're at a stop sign or waiting for a stoplight, or they're napping when they don't really want to be. Or male gender is actually a risk factor. More men than women have the problem. Large neck circumference. I had somebody was actually giving a talk on sleep disturbances, and he went up to a couple of, actually they were all men at the conference, and said, you must have some problem, because their neck circumference was just obviously very large, or larger than average. And alcoholism, again, is an important risk factor for sleep apnea as well. And there is some evidence of an association with dementia. And home-based diagnostic systems may be helpful in identifying it, but otherwise a referral to a sleep lab, and they can do, they'll do an office assessment first and then schedule them for the sleep assessment and get the testing done during that assessment that they need the information. They'll determine what tests they need to do during the sleep assessment. The main treatment is now a nasal CPAP. They've got a lot of new equipment that they didn't used to have. So if people had tried equipment like 10 years ago and it didn't work for them, they let them know that there's maybe a new option for them available, more comfortable equipment that might be something that they would want to look into now if they couldn't use the big masks in the past. Periodic limb movements. Again, we talked about periodic limb movements during sleep. And again, if they have a bedmate, it's more easy to get a history. But it's a debilitating, repetitive, stereotypic leg movement that occurs during non-REM sleep. And that's usually the kind of sleep that older adults are getting in the whole night. So it can happen at any time during the night. And it presents as a difficulty maintaining sleep or excessive daytime sleepiness. The prevalence of this increases with age, so younger people don't get it as often as people with advanced age. So you're going to be hearing about it a lot more than you would in a regular adult population. And it's associated with sleep complaints, and it can't be explained by another sleep disorder. Restless legs is the uncontrollable urge to move your legs at night. Symptoms occur while the person is awake. They'll say that I even have it during the day. Like right now, I'm getting that feeling in my legs and I got to get up and walk around a little bit. Or they'll say that to you. It can also involve the arms. So if the person is aware of the sensation and they have to get up out of bed and walk around a little to get rid of it during the night, then that is something that you might want to consider, is that they're experiencing restless leg syndrome. And there is treatment for that. And the prevalence with this also increases with age. You don't need polysomnography to diagnose restless leg syndrome as you would for the periodic leg movement syndrome. And many patients with this also have PLMS, interestingly enough. So then you have to differentiate between the two just to complicate things more.
Right, and you'll check their vitamin D levels and
Yeah, when
you
I
know, so
yeah, that's stuff to check with people because a lot of people get these leg cramps and things. I've had calcium deficiencies appear as leg cramps, and it's been mistaken for restless legs, and they started taking calcium and it went away. I've also had people with very low vitamin D3 levels, and then when I checked that and they replenished their vitamin D, surprisingly the symptoms went away as well. So there might be some simple ways to get rid of the symptoms.
Yeah, I heard a presentation by a physician that works with restless leg syndrome patients. He has it himself. And he also talked about checking a CBC, looking at the red counts to see if there's any anemia there. And sometimes it still might be in normal range, but what he did was he would supplement with a little bit of iron. And, he found that some of his patients they had decreased restless leg symptoms then. So you might want to check a white count and also check their CBC for their red count and check a vitamin D level as well.
So otherwise, if you're going to treat it with other things besides vitamins, if you've really determined that there is no other problem and you're going to go with the diagnosis of restless legs, a dopaminergic agent is the agent of choice. Some of the Parkinson's medications, you can choose the really old-fashioned levodopa carbidopa if you want at a very low dose, or choose one of the newer agents for Parkinson's at a very low dose. The important thing is not to take it right at bedtime, but an hour or two before bedtime when you're so it kicks in before you actually lay down to go to sleep. Otherwise, it'll keep you awake right away. So the drug reps that recommend this treatment with their products will tell you, make sure they take it an hour or two before they go to bed, not right at bedtime.
Okay.
And an evening dose is commonly used for people with frequent symptoms. And a nighttime dose of carbidopa, levodopa, which is off-label use, I have to tell you that, but it can be used for people who need medication infrequently. And gabapentin can also be effective, but it's more expensive than carbidopa, levodopa. Disturbances in the sleep-wake cycle can occur. A delayed sleep phase, like you fall asleep late and then you awaken late. So people these are what you call night owl people. And if you were like that all your life, you might be just stuck in this pattern. If you worked nights all your life, you might be we've had people in the nursing home that just couldn't switch around and sleep at night. They were just more alert during the night hours, unfortunately. Didn't fit with the new schedule of their life, but that's the way it was. Also, the advanced sleep phase, people fall asleep early, they awaken early. And that's particularly common in older people. They have nothing going on in the evening, nothing good on TV. They go to bed.
No ball games.
No ball games. Yeah, after Packer season's done, they're done. So they're waking up early too. And then people with a significant disturbance can always go to a sleep lab for evaluation to see if there is a physical reason contributing it. Sometimes there's no reason at all that comes out of those evaluation. So be prepared that you might not get the answers you're looking for from the sleep evaluation. And problems related to either condition may respond to appropriately timed bright light. If you just are exposed to, you can buy a light that has, the light that you sit under for 15 minutes a day, or you can sit outside if the weather is decent and get exposed to bright light rather than sitting indoors. And sometimes just having light exposure during the daytime hours will help you sleep better at night. Older people with dementia might have more sleep disruption and arousals. They might have lower sleep efficiency so that they are laying in bed when they don't really sleep in bed, but somebody puts them there for a little break or respite and they're not really sleeping. And then a higher percentage of stage 1 sleep and decreases in stage 3 and 4 sleep are common with dementia. There are also disturbances of the sleep-wake cycle that are common with dementia. Daytime sleep, which might give the caregiver a little break during the day so they can get something done, but it's really bad at night when their spouse is awake all night, getting into mischief in the house, and they're trying to sleep. So people like that, that's actually a very common reason for institutionalization is when the sleep-wake cycle is so disturbed that they're awake all night all the time. Not be reversed. Factors contributing to insomnia in the hospital include the illness itself. You just feel so sick, or you have so much pain or trouble breathing or whatever that you cannot sleep well. People are checking on you more often, so that they're interrupting your sleep. Medications that you've been given might cause you to sleep during the day when you don't want to be sleeping, and then you're awake at night. Change from your usual nighttime routines. You're not taking your shower, drinking your hot chocolate or your herbal tea, and then watching your favorite TV show, and then maybe you have a roommate, and your strange noises, all that type of thing. It's a very sleep disruptive environment. There's announcements overhead on the pager out in the hall, and it might be lighter. There might be little night lights all over your room that you're not used to. The mattress isn't comfortable, whatever it might be. But non-pharmacologic interventions can help. Daytime bright light exposure we talked about earlier. A change in medication times to allow people to sleep later in the morning. Like maybe you don't want to take your meds right at 4 or 5 o'clock or 6 o'clock in the morning. Wait till you get up at 10 o'clock. And sometimes a back rub, which those are few and far between nowadays. But if somebody's available to do that, it is relaxing. A warm drink like herbal tea, something that doesn't have caffeine in it, or a relaxation tape. There are a lot of those available. Some of them are really nice. They have harp music on them that it starts out at a more rapid pace, and you're trained to tune yourself into it, and the pace of the rhythm gets slower and slower as the tape progresses, and people can relax based on that tape. But that does take practice to use that device. So sleep problems and institutionalization, I did mention earlier, up to 70% of caregivers, and this would be like the spouses or adult children of people with dementia, people report that 70% report that nighttime difficulties played a significant role in their decision to institutionalize the older person. It's usually because the sleep of the caregiver was being disrupted. I mean, you cannot work 24/7. Taking care of an individual, you have to get some respite yourself. So most people either hire an overnight caregiver in their home, which might be cheaper than going to the nursing home, or they have to institutionalize the person for their own health and their own sake. And causes of sleeping disturbances in their sleep difficulties in long-term care and nursing home settings are multiple physical illnesses, as we talked about earlier. The need to come in and check your blood sugar by poking your finger at 5 in the morning, all the way up to not being able to breathe, having oxygen on, having, a diuretic and having to urinate or having your breath changed during the night. Use of psychoactive medications, debility and inactivity, so you're not really even tired at night. They're putting you to bed at a certain time just because it's time and you're not really tired. The increased prevalence of sleep disorders due to dementia or other causes. Environmental factors, nighttime noise is very common. Light, turning on the lights to take care of a roommate or even you. And disruptive nursing care, like the blood sugar checks are a good example of that. Or people bringing linens in for the next day, or dropping supplies off and putting them in your closet at 5 in the morning, so forth. And then lack of exposure to bright light during the day. One study found that the average duration of sleep episodes during the night was only 20 minutes, and then how sad is that? I mean, so what are some of the non-pharmacologic interventions that can help? Since the nursing home surveyors don't like to see Ambien, they don't like to see benzodiazepines. What can you do? Morning exposure to bright light can help. Structured physical and social activities so that the person is occupied and busy, not just sit. Some people say, well, they were up all day or they were watching TV in the lounge. Well, they weren't. They were sleeping in front of the TV in the lounge. I mean, that's not really a structured activity. And then nighttime interventions to decrease noise and light disruption. The staff has to be very aware of the noises going on. Some nursing homes have even put a tape recorder in a room and let it, run all night, and they actually taped the noises that were audible in that room, and they could hear people laughing at the desk. They could hear people's radios on. They could hear staff hollering up and down the hall at each other. They could hear the cart, going up and down. Yeah. So there's a lot of noise that you don't realize is there unless you really make an effort to listen for it. And these aren't people that are used to being home alone and in the dark, and then they come to a setting like that. It does make a difference. So how do you manage sleep problems? Well, the starting point is not to put them on a sedative hypnotic agent. Identify what the cause is. It might be just that they don't sleep without a light, or some people cannot sleep without a night light on, and some people need a light or want it completely dark.
That's interesting because you want their melatonin to come out so that their natural melatonin, so
Right.
they can sleep. So you would think it would be more, conducive to have a darker environment. But you do get people, like you said, that they have to have a little bit of a light on in order to sleep.
And I don't know if it's the reassurance of being able to see what's
When they get
going on when they get up or whatever. But,
Safety,
yep.
perhaps.
But those are all things. And then if the history and physical exam do not suggest a serious underlying cause, start with a trial of just sleep hygiene. Make sure they get up at a regular time every day, that they have a regular bedtime unless they're not sleepy. Decrease or eliminate naps. Someone really has to stay on them and make sure they're awake all day. And it's hard to do when it's easy if you're the only caregiver, like it's one-on-one with a spouse. But when you're in a nursing home, how do you keep track of who's asleep and who's napping and whatever? It's not as easy to do in an institutional setting. Make sure people get exercise daily, but not immediately before bedtime. That's a stimulating activity that might actually keep them awake if they do it right before bed. And don't use the bed for reading or watching TV, only for sleeping. Relax mentally before going to sleep. So don't go for a big card game where they're getting all riled up and then say, I'm going to bed now. Make sure that you have some mental relaxation. And then if you're hungry, have a light snack. This is important for diabetics, especially that are on insulin. But people that have GERD or other medical contraindications to eating heavy meals at bedtime should avoid them. But most people, if they're hungry, should have something like just a cheese and crackers
Right,
and
a
a
little
glass
protein
of milk. Yeah,
might help with the sleeping.
Yep, carries them through the night. So should also eliminate or limit alcohol, caffeine, and nicotine. All three of those. Wind down before bedtime. Have a regular scheduled bedtime. Maintain a routine or a period of preparation for bed. This is just kind of like working with children. You brush your teeth, you wash your face, you maybe say your prayers, or whatever it is. You have a little routine at bedtime, and then you go to sleep. Control the nighttime environment with comfortable, cool temperature, quiet, and darkness. Try a fan or other white noise machine. There's some really nice, inexpensive white noise machines too. They're like $20, and you can pick a forest or the waves rushing, or just the white noise, whatever you like. Wear comfortable bed clothing. Some people wear a nightgown. They put a long nightgown on something. They get all twisted up in it. And they can hardly move. But make sure that they have comfortable clothing on. If they're not able to fall asleep within 30 minutes, they should just get out of bed and perform a soothing activity, but avoid bright light, and get adequate exposure to bright light during the day. That's very important with melatonin formation. To improve sleep efficiency, you look at the sleep efficiency is the time of sleep divided by the time that they're actually in bed. And we already talked about some of these, but keeping a sleep log will tell you how sleep efficiency, what their rating is, but also the same interventions that you would use for stimulus control applied in sleep restriction. The cognitive interventions would be to identify their dysfunctional beliefs and attitudes about sleep, like I need 8 hours of sleep, I have to be in bed by 9 p.m., things like that, that I need to be in a deep sleep. Educate people to change these false beliefs and attitudes, because they have to know what's normal for aging, and that they shouldn't expect to sleep 8 solid hours without having to get up anymore. That's not realistic, and most people don't know that when I've told them that. And then relaxation techniques, these generally take practice, but it's something that you can work with an individual in your spare time during your 15-minute office appointment. But really, these are things that can be taught. Even in therapy, people can use biofeedback and things and learn how to relax muscles, and the therapists can work with them. Nurses can too, if you're in a setting where you have the time.
Right.
I mean, you can teach people to use these techniques. I have a friend that has her own nursing office, the lucky NP, and she does a lot of counseling, and she does a lot of headache management, but she does teach relaxation techniques, and she has 1-hour appointments and she bills insurance for it, and does a lot of these relaxation techniques. So
Right, because sometimes even just deep breathing, 10 deep breaths. I know some of the clinics I've been in, we've had some examples of the relaxation tapes that we can suggest to patients and let them know where they can get them, whether it's Target or Shopko or wherever. And sometimes that's really helpful, especially if they come in with a son or a daughter or caregiver that can go and purchase the things for the patient. So a lot of different things that can work.
there's a lot of nice stuff out there.
There
really.
is,
Yeah,
right.
you just have to find them.
Right, and know about.
And then bright light, that corrects the circadian rhythm, which is actually a physiologic thing that you can influence by using bright light or taking melatonin. And it does tell you the amount to use and the amount of exposure that is recommended on this slide. And I don't really use a lot of meds for sleep. For one thing, they have side effects that you don't want to sedate people that are going to bed, and then if they have to get up during the night, what are they going to do? Fall. Or they might get confused and disoriented, not know where they are, and have an accident. So if I do use something for sleep, I typically will use trazodone, which is a very old antidepressant. I use a very low dose. You should start people on 25 milligrams. And I very rarely have gone above 50 with people. And it usually works really well for a couple weeks, and then the effect somehow wears off. So if they can get a good sleep pattern in a couple weeks, then maybe they can continue on their own. You don't want them to get in the habit of using medication at bedtime, although some people do develop that psychological dependence that they need a pill to fall asleep. One thing I never use is the benzodiazepines. I was taught in my geriatric program that the only time to use those, well, there's 2 times. Alcohol withdrawal and end-of-life symptom management, when people are actively dying and you need something to use. And those are the only 2 times that you would use the benzodiazepines. So even with trazodone, you do have some side effects, but it does tell you how to avoid those on the slide. And non-prescription sleep products are used, and I believe this, used by nearly half, I think it's probably more than half of all older adults. When they give you their med list when they come in the office, ask them about over-the-counter stuff, like do you take any vitamins, take any Tylenol PM, or, oh yeah, then they come up with these. That Tylenol PM is on almost everyone's medicine cabinet, and it's a very common medication that people purchase. They don't even think of it as a sleeping pill. In fact, they think of the Tylenol part of it, and they don't think of the Benadryl part of it. Melatonin, most people that are older adults don't know about it. It's used a lot in pediatrics as well, if any of you have worked in peds, but it's very effective in older adults too, and it's used primarily in circadian rhythm disturbances. So if people have problems like with advanced sleep stages, or they're going to bed too late at night, they might want to take melatonin a little earlier. And
people who fly across time zones will often use this too. So if you fly from here to Europe or South America or whatever, this is very common for travelers. Also business individuals use this a lot.
Yep, and you can buy it over the counter.
Right.
And people will ask about the doses, and I just tell them to follow the instructions
Right.
on the label. And
That's what I do, follow package insert. And I document it that way too.
yep. And things that are generally not recommended, I think we talked about, well, a couple of them. Anything that's sedating, antihistamines, like Sudafed, things like that. Alcohol, because it interferes with sleep later in the night. You might pass out initially, really, and be
Yeah.
sound asleep, but you're going to be awake within a couple hours, and it's just got the opposite, like a rebound effect where you won't be able to get back to sleep.
Valerian, I've had some patients that have used valerian. It's tea. It doesn't, I mean, you can buy it right at the grocery store. It doesn't have the greatest odor to it. You can also buy it in capsules and a tincture. So I've had patients who have used this. There's also another tea called Sleepy Time that people sometimes will use as well. They really aren't harmful. And so if I have people who, patients who think that it works, I always recommend it basically. Because if the worst thing that can happen, they're out a few bucks for the box of tea. It's not going to make them so drugged up like if you were using something like Ambien or some kind of hypnotic. And you all know, you've probably all heard about Ambien, that for women, they've decreased the dosage. Well, for older adults, really only 5 milligrams, but for adults, for women, they decreased it, they're suggesting from 10 milligrams down to 5 milligrams, and that was a recent change. Okay, that ends this